I'm Tess.
I'm John.
I'm Logan.
I'm Becca. So we're your first year liaisons for SAO, and so this year we're going to be making you videos, study guides for OPP to help prepare everybody for that. And this time around we're going to be doing OA, AA, C2 through C7, and also diagnosing incontinence.
And Counterstrain.
And Counterstrain.
What we got here is a skeleton. We got left translation is inducing right side bending, as you can see. We got right translation coming right there, just like an arrow, inducing left side bending. So that's just a little bit to get on the same page for translation and side bending. Review of the OA diagnosis. So we're going to start out with the occiput. Take the occiput, translate to the left, translate to the right. So going back and forth. See which side is more restricted. Seems like the right is more restricted. It's harder to go to the right side. Therefore, we're side bent to the right, rotated left. Now we go to C1. So we find the mastoid process right here. Go a little bit inferior. Then we go anterior. And then what we do is pick up the head on C1. We translate to the right. We get some side bending going with that. Translate to the left. Seems like it's restricted to the right. It's harder to go to the right. Therefore, we have side bent right. What side are we rotated? To the left. Opposite for OA. And now we go to the sulci. Find the sulci. So we just bring our hands to that occiput. Crawl down. So we find that little occipital sulci here. And we try to feel which side is more shallow. Is it the left? Is it the right? Seems like the right side is more shallow. Therefore, we are side bent to the right, rotated left. And to confirm that, you can also pull up on that sulci. And it seems like there's a lot more give on that left side than that right side. So that just confirms we're side bent to the right and shallow on that right. Just for some clarification's sake on the OA diagnosis here for the practical. There are the three ways that we just showed you how to do it. But for the practical, make sure that you are confident with one of those techniques and that you can explain very clearly that you are which method that you're using for the practical. Okay, so we had side bent right, rotated left so far as the OA diagnosis. Now to treat it, we need to find whether it's a flexion or extension dysfunction. So before that was all in neutral. So now we're gonna put the OA into flexion, and I'm gonna use the translation of the occiput to figure out whether or not this is a flexion. Okay, so you go flexion, and you put her in extension. Okay, she doesn't like this. She does not like the extension. And make sure you're only extending to that OA joint. That's important. So she didn't like the extension. She likes flexion. So you're going to name it for what she likes to do. So we have flexed, side bent to the right, and it's rotated left as our diagnosis. So the treatment is just putting in all the opposite planes of that. So we're going to go into extension, side bend to the rotate to the right, side bend to the left, and now because this is an extension, the treatment is going to be flexion. So we're going to put our fingers underneath the chin and ask the patient to tuck their chin for 3 to 5 seconds and release. Then you're going to go into extension just a little bit more, rotate a little bit more, side bend a little bit more, and flex, and release. You'll do that one more time, and you'll bring the patient back into neutral, and then you will check once again, and then that's your treatment. Okay. So with the OA, just remember that we have type 1 mechanics here. So the side bending rotation are the opposite of each other. Make sure you do a passive stretch after your treatment. And also, last thing is to make sure to check and see if your patient improved. So you'll just go into extension and flexion to see if the side bending dysfunction improved. All right, now we're doing the AA diagnosis. We just did the OA diagnosis. So the AA, remember that joint is between C1 and C2. So this one is very simple. You're just going to pull the head up to roughly 45 degrees on most people, but the important part to remember is that you're going to go until you feel some tension back there with that trapezius muscle here. So you'll go until you feel that tension. You'll just have two fingers in front of the ear here, and you'll just rotate to the left and rotate to the right. Feels like it's harder to go to the right side, therefore the restricted side is to the right. That's all we need. For treatment now, we're going to go to the side of the restriction, going to the barrier. And now what we're going to do is just simply ask the patient to turn their head to the left, applying resistance for 3 to 5 seconds, and release. And we will go to the new barrier, ask the patient to turn their head to the left for 3 to 5 seconds, and release. Do that one more time. Go to the barrier, patient turns the head, 3 to 5 seconds, and release. Do a passive stretch to end it. Going back to neutral. Then you can check again to see if there's any improvement. That's the diagnosis and treatment of the AA. All right, so now we're diagnosing the C2 to C7 vertebra here. And what we're going to do is just bring our hands here, 45-degree angle. Find that C2 right here, that big bulging spinous process would be C2. And to go down the spine, we'll just go one finger down, should be C3, another finger down, should be C4, and so on and so forth. So to diagnose the spine, we'll get our middle finger here on those articular pillars. We'll get our index finger on the transverse processes here. We'll pick up the head, and what we're going to do is just start translating to the left, translating to the right, to find a transverse process that is restricted, and it seems like right here we have a restriction. It's harder to go to the left, so therefore it is side bent to the left. Because these are type 2 mechanics, it is therefore rotated to the left as well. Okay, so we were at the C4 that we found it was rotated left, side bent left. So that was our diagnosis, but we got to put that into flexion and extension now to finish out our diagnosis before the treatment. So we'll just take the patient's head, put it into flexion up to that C4, translate to the left, translate to the right, and put them into extension to C4, translate to the left, translate to the right, and it feels like it's harder to translate now in extension. It's easier in flexion, so therefore it's a flexion diagnosis. So we were flexed, side bent to the left, rotated to the left as our diagnosis. Remember, that's what it wants to do. So the barrier now is what we're going to put them into. So we're going to put them into extension at C4, going to rotate to the right, going to side bend to the right, and now we're going to have the patient rotate to the left. 5 and release, and we're going to rotate a little bit more, side bend, make sure you add a little bit more extension as well. Have the patient rotate to the left, and release. And then once again, we'll do that one more time. Rotate to the right, side bend to the right, extend, have the patient rotate to the left, into the freedom, and release. Remember the passive stretch in all three planes of motion. Bring back to neutral. Recheck it just to see if there was improvement. Hopefully there was, and then we're all good.
Alright, so the next thing that we're going to do is counterstrain. So counterstrain is a little bit different than muscle energy because it's an indirect method. So you put the patient where they want to go, and which is also into their freedom. Alright, so what we're going to do here is we're going to go over tender points, which tender points are what we use to diagnose for counterstrain. So you go through here and you're just going to palpate down and ask the patient if it hurts at each point. So does this hurt?
Oh, yeah.
So this hurts really bad right here, so we're going to say it's a 10 out of 10. So then we want to flex and then rotate away, side bend away, and then ask the patient again on what's your pain score now?
It's about a 2 out of 10.
2 out of 10, that's good. So you want to shoot for 3 out of 10 or less. So then you'll hold the patient here for 90 seconds. So 1, 2, 90. And then you will put them back into neutral. And then you ask them again, you know, what's your pain score now?
It's about 2 out of 10, I think.
2 out of 10. That's good because you want to be 3 out of 10 or less. And that's pretty much it for tender points. All right, so now we're going to try to explain a little bit more about the anterior tender points and what that is. So what we're going to do is we start out with finding C1. So you'll kind of follow up the jawline up here, and then just a little bit lower than that should be the C1 transverse process. And so you want to palpate down the SCM muscle, and you don't want to go over here because their carotid is there and you don't want them to pass out on you while you're doing this. That's not good. So you're going down, and so it goes from C1 to C6, and then you get down here and it's C8, and then C7 is actually about mid-clavicle, so it should be over here. And so for the counterstrain, for the actual treatment, each one's a little bit different. So at C1, you would rotate away, and that's it. And then for C2 through C6 and C8, if he said this hurt here, then we would flex and do the side bending away and rotating away. And then for C7, which was mid-clavicle, we're down there, that's the F star, so you would side bend towards and rotate away for that one. Okay, so next we're going to do the posterior tender points, which again is what we use for a diagnosis to do counterstrain. And so what we can do here, so you go from C1 to C8. C1 starts at the occipital protuberance. You do the same thing as anterior. You just would palpate down, ask the patient if it hurts. So C1 is a little bit different. So C1, you would just flex the patient if they said that it hurts there. And then C2, C3 is a little bit different. So C3, it's F star. So you would flex them. Oh, something else too. So I'm feeling midline, but really you're feeling on either side of the spinous processes. And so like if this side of the spinous process is what's bothering them, so it's F star at C3, so you would side bend toward and rotate away and flex them as well. And then, so for all of the other ones, it's E Sarah, which is extend, side bend away, rotate away. So I'll kind of do it on the same side of the spinous process as before, but down here a little bit. So we would extend, side bend away, and rotate away for that. And something else too is that you can feel laterally for the tender points on either side, but you would just do one side at a time. You wouldn't feel them both at the same time. And just as you're going down, ask the patient. And once you find a point that they say it hurts, say that that's a 10 out of 10, and then do the counterstrain treatment.
Should I sit like this, you think? Yeah? All right, so we're explaining some anatomies here. So we got our pelvis, we got our PSIS back here, we got our AIS up front. So after we did our standing flexion test, that's the side we know we'll base our diagnosis off that. So let's say we got the positive standing flexion test on this side here. So we'll look at the PSIS and the ASIS. If we have a lower PSIS and a higher ASIS, then we're going to have a posterior innominate. It's going to be posterior, as you can see there. But if the ASIS is lower and the PSIS is higher, we're going to have an anterior innominate, as you can see that going anteriorly. And now, if both sides are elevated, then what's that? That's an upward shear or a superior shear. And then if both sides are lower, then we got an inferior shear. And that's pretty much the pelvis in a nutshell. Okay, so what we're doing here is finding the PSIS to be able to do standing flexion test. So we'll start finding the iliac crest. You should be able to feel that very easily. And what you're going to do then is just follow the iliac crest down as it curves down, and we're looking for that PSIS. So that should feel that protuberance that's just down following the iliac crest. And then what you do is when you feel that you found it, you go just a little bit lower, and you should be able to hook underneath it so that just even a little bit of pushing up should push her up in the air. So when you feel that you've found it, you compare sides, and as the camera can see, looks like it's slightly higher on that left side here. So what we're going to do now is have Rebecca flex forward for us, bend forward at the hips, and we're going to see if a side moves. So it looks like that left side was moving up here. So she's going to have a positive standing flexion test on that left, and you can come back up for us. So we know that it's the left side that we're going to base the diagnosis off of. Okay, so now the patient is turned around, so we're finding that ASIS. We look for the iliac crest, found it right here. Then we follow the iliac crest to that ASIS, which should be that bony protuberance. And then what we do is we hook our fingers underneath it to see what's the level of it. It looks like this left side here is lower than the other side. So our positive standing flexion test was on that left. So because it's lower on the front side and higher on the back, it's going to be an anterior rotated innominate. And just to show you that, so here's our left side. The PSIS was higher, ASIS was lower, so it'd be an anterior rotated innominate.
Everybody get up, it's time to slam now. We got a real jam going down. Welcome to the Space Jam. It's your chance, do your dance at the Space Jam.